Welcome to the MSRC Fall Conference Online. I'm Gary Jeroman, and my presentation today is Current Settings for Quality PAP Mask Fitting in the 2020s. Before I continue this presentation, I'd like to state that I have no real or perceived conflict of interest that relates to this presentation. Any use of a brand name or manufacturer is not in any way meant to be an endorsement or a criticism of that specific product, but merely to illustrate a point of emphasis. The objectives of my presentation today are: list the different types of mask fit situations, discuss the elements of the successful mask fit, list the activities in the traditional mask fit protocol, describe the main purpose of the facial assessment, know the indications for selecting a mask interface type, describe how mask sizes are determined, differentiate significant from insignificant mask leaks, describe the factors for contributing to mask leaks and the techniques to fix them, describe the current pandemic methods now for doing a mask fit, and differentiate between 2D and 3D facial scanning, which I believe are in our future. In the 1970s, Dr. Colin Sullivan began researching obstructive sleep apnea at the University of Sydney in Australia. Dr. Cullen was the first physician to believe that positive pressure ventilation, aka CPAP, could effectively treat obstructive sleep apnea. This picture was taken in 1979. It shows the first patient being treated with a CPAP using the first CPAP mask. Note that the interface that was used is not the typical mask that we see today. Rather, it was a custom-made fiberglass molded mask used to cover the nose, and it was held in place by using silicone glue. So why would Dr. Sullivan go through all the trouble and work to create this custom fiberglass mask that fit the nose when he could have used an oxygen mask and tried to adapt it to large bore tubing? Well, as best as I could determine was that he did try the oxygen mask, but it leaked and it couldn't hold pressure. In this picture, I'm showing you one of the very few respiratory relics that I have from the 1980s. This was the first commercial mask manufactured in 1987 by Respironics. As you can see, it has some familiarity with the current nasal masks that we use even today. The mask had two adjustable straps, plus the foam pad that fit over the bridge of the nose to prevent pressure on it that came by size. And finally, it had on the bottom what's called the whisper swivel today, or an exhalation port. The mask came in three sizes: small, medium, and large, and there wasn't any other manufacturer. Matter of fact, there were no pillows or full face masks there. This is all that you had to work with in the 1980s. In this slide, I'd like to show you a few of the numerous mask fit situations that require a planned strategy in order to succeed. They all are different and have a need of a different approach. And the first one are basically our new setup, either of a CPAP or a BiPAP. This is a teaching situation in which we must emphasize practice. We're trying to coach the patient with regards to how to operate the equipment, how to put on the mask, how to troubleshoot, how to clean. So we're teaching this patient, and we also should be going back to see if the patient is retaining this and understanding it. We need a lot of coaching in this situation, and we're also at the same time trying to reduce stress and anxiety the patient may have of doing this. The second situation is totally different: claustrophobia. Desensitization is the biggest thing that we're trying to do. The patient cannot tolerate putting the mask on, is too fearful of this. So we use a desensitization protocol in which we gradually, over time, increase the patient's contact with the mask, from holding it to putting it over his face to putting it on his face, and then increasing the time that he keeps it on his face to overcome his fear. It takes a lot of patience, and sometimes it takes a lot of time, but it can be done. The next situation is non-invasive ventilation by ventilator, and in this situation, speed is extremely important. We are trying to avoid intubation, which through the pandemic we've learned has a high mortality rate. We're trying to achieve a minimal leak with a good fit, but sometimes a minimal leak is very hard to get, and so we're looking for an acceptable leak. In the mask refit situation, there's many, probably more different variations in here. You can have the patient that has used the mask for a long time, and they simply want to look at another type of a mask or a new mask. But where you really need a strategy is when you have a patient who has failed either CPAP or BiPAP by failure to make compliance. He hates the machine, he hates the mask because of his failure, and is trying to convince the patient to accept the mask and continue. The next situation is the pediatric mask fit. This is a situation that the child has had the tonsils removed and there is subsequent swelling that caused airway obstruction with the need for CPAP via mask. The goal here is to try to get the patient to wear the mask. Unfortunately, the child doesn't understand, and that's where the mother or the caregiver is needed to play the games with the child to get the child to accept the mask. Usually the mother will wear the mask, then the child will put the mask on the mother's face, and then through the games, the mother will place the mask on the child's face, and the child becomes accepting of that. But this, again, is a different type of a strategy than simply going through instruction. Finally, the last situation I'd like to show you is the difficult mask fit. And I call it that because basically we have a patient who is on a high pressure, could be 30, he could even be on a ventilator, 35. The mask doesn't fit. They've had 3 or 4 previous failures, and usually there are facial irregularities that create leaks by themselves, but the high pressure exaggerates that. So getting the fit is absolutely important, but it's overcoming these obstacles and doing that. I want to take this time to talk about protocol, which is often confused with policies and procedures. Policies, as best as I know, are an organizational declaration of rules, practices, beliefs, such as wearing masks, sick leave, or uniforms. Procedures are step-by-step instructions on performing a task such as aerosol therapy or pulse oximetry. Protocols are a little bit different. Protocols are a written plan similar to a procedure, but in it identifies specifically procedures to be followed specifically in a defined situation, such as weaning protocol. I've worked at a large number of hospitals and home care companies who had excellent policies and procedures covering nearly all the respiratory therapy activities. However, when it came to mask fitting, there was hardly any policies or procedures to be found. It was assumed that respiratory therapists had this very instinctive notion and knowledge of how to do it without much training, and no policies were needed. But I think with regards to non-invasive ventilation, with regards to working with kids, with all of these specific situations, that you do need not only a policy or a procedure, but you really need a protocol that spells it out. I would like to once again reiterate the goals of the mask fit. We are looking to achieve a mask fit that has the lowest non-significant leak that minimizes apneas, hypopneas, and RERAs. That is, keeping the occurrence of them to less than 5 per hour. Attempts to achieve a mask fit that is both comfortable and non-painful to the patient. Selecting a mask type that the patient can easily put on and adjust. And finally, provide the patient with the support, confidence, and assurance in using this mask. The traditional mask fit protocol is a series of activities that are designed to improve the quality of the mask fit. They include asking the patient the essential questions, assessing the face and the head, selecting the mask interface and size, select effective headgear if necessary, fitting the mask interface and the headgear to the patient, but in this case allowing the patient to do this to give him more practice, assessing both the comfort and the leak rate on the mask, and finally assessing the patient's skill to put on and adjust the mask. Before we proceed to the mask fit, we need to collect specific data through a series of questions. Has the patient ever been fitted with a nasal mask before? The patient who has never worn a mask before is going to need a lot of attention compared to the experienced user who has used the mask. Look at the complete prescription and particularly the prescribed inspiratory pressure and the prescribed mask. You may find some differences with that. Does the patient have claustrophobia, TMJ, insomnia, dentures, or any type of skin irritation on the face? These, again, will be important considerations when selecting a mask. Can the patient lift his arms above his head? Again, another factor for success. And what sleep position does the patient more commonly use? A patient who sleeps on their stomach is going to have trouble if the mask has an elbow on it, which is likely to break with a lot of pressure. Another consideration with sleep positioning is those patients that sleep on their sides. And in regards to the mask, the lateral pressure from sleeping on your side may dislodge the mask and cause a leak. The assessment of the face and the head is really a search of the facial surface for irregularities. Irregularities are the depressions and the raised areas of the skin that are likely to impact the cushion and cause leaks. So we're going to look at facial hair, we're going to look at skin disorders, paralysis to the side of the face from a stroke or Bell's palsy, indentations in the bridge of the nose from heavy glasses, deep smile or frown lines, the asymmetry of the face, the difference between the left and the right side of the face. The greater the difference, the more probability of a leak. We're going to look for scars, tumors, missing teeth, dentures, high cheekbones, broken noses, and deviated septums. All of these irregularities can have profound effects upon the success of using a particular type of a mask. Before we go into mask selection, I wanted to show you the differences between the mask types used in home care and the hospital. In home care, the masks are permanent. That means that they can be re-cleaned. The manufacturer recommends that permanent masks be replaced between 3 months and a year, depending upon the insurance company. The disposable hospital mask is meant for a single patient. Comes in a sterile package, and it is meant to be used for a few days or a few weeks and then disposed of. The next difference is between vented and unvented masks. Vented masks are primarily used in home care and have a fixed hole or orifice in which the gas escapes with the CO2. This hole is of a uniform size that allows the machine to regulate the pressure effectively. Non-vented masks use the exhalation port on the ventilator for eliminating CO2. Home care uses a variety of masks from pillows, nasal masks, full face masks, hybrid masks, and total face masks. Generally, the hospital has a limited supply of masks, as usually they include the full face mask, the total face mask, and of recent times, the helmet. The helmet is one of the latest inventions for the use of non-invasive ventilation. The helmet is a cylindrical bag that easily fits over the patient's head and is secured around the neck and with straps that go underneath the arms to hold it in place. The mask has ports for the inlet of oxygen and air and an exhalation port that can be filtered. The benefits of the helmet include patient comfort. It can rapidly be placed over the patient's head without extensive fitting. None of the common problems as with a mask. It can also hold high pressures, and the exhaled air can be filtered. The nasal pillows are the first of 5 mask interfaces used in home care. They were first introduced in the early 1990s. They are considered the most comfortable mask interface. On the screen are the 3 most popular types of nasal pillows: the Respironics DreamWear pillows, the ResMed P30 pillows, and the F&P Nuance. With nasal pillows, the pressure range that are effective are 4 to 10, although the newer pillows often state that they can go up to 15 without leaks. Probability of leaks are low depending upon pressure, and their indications are for low pressure patients, patients that want comfort, patients that have claustrophobia, or patients that are handicapped in their ability to put them on with a single hand. One major disadvantage to the use of nasal pillows are mouth leaks. Oftentimes it's never mentioned or revealed during the mask fitting process, only to be discovered after a couple nights when their sleep apnea returns because of the loss of pressure. The remedy for that is to try to use a chin strap to hold the jaw in place. The next mask type interface is called the nasal mask. It simply fits over the nose and is held in place by straps. This is the first manufactured mask that was produced in the early 1980s after Colin Sullivan had invented the CPAP unit. There was only one mask at the time, and it was the nasal mask, and it came in small, medium, and large. There were no other types of masks available, so this is all the patient could get. The design of the nasal mask from the 1980s has evolved from covering the full nose to covering half the nose to covering the tip of the nose, and now with the DreamWear, the mask fits snugly underneath the nose similar to the nasal pillows. The three most popular nasal masks that are out there are the F&P ESON nasal mask, the ResMed N10 mask, and the Respironics DreamWear masks. Basically, the nasal mask has a range from 4 to 15, although the newer masks state that they can go much higher. The probability of a leak is low to moderate, depending upon the pressure. The full face mask is a type of mask that allows the patient to breathe both through their nose and through their mouth. The original full face mask was designed and produced by ResMed in the mid-1990s. The design of the mask allows for pressures to range from 4 up to 20 and beyond, with leak probability being high as the pressure gets higher. The indications for the full face mask are for mouth breathers, patients that have dentures, patients that have craniofacial deformities, and patients that have beards. I've shown some of the more popular full face masks. They are the F&P Viteria, the ResMed F20, the Respironics Amara View, the ResMed Mirage Quattro. This is the same mask, similar, updated a little bit from the original one that was in the mid-90s, the F&P Simplis, and the Respironics DreamWear full face mask. There is no part of the mask that covers the nose, but rather it slides underneath the nose with a kind of a passive fit. It doesn't intrude into the nostrils. The total mask interface is different than the full face mask in that it covers the entire face. The design of the original total face mask had this cushion on the inside that covered all of the sides of the face, the top, and rested between the lips and the chin. This mask was generally used when the attempts to use all other masks failed because of the high pressure and the great leaks. It was not tolerated very well by the patients. It was large and clumsy, and although it did afford the patient to view, but they had to strictly be positioned on their back and it could not roll on their sides. Sometime about 2010 to 2012, Respironics came out with their improved total face mask, which is called the Fit Life. The pressure range for the total face mask, or the Fit Life, is from 4 to 15, although the pressure has been used higher. The leak probability is moderate to high, depending upon the pressure. And indications for the mask are for mouth breathers, facial pain, and basically uncontrollable leaks when no mask seems to fit. The idea behind the total face mask is to avoid all of the irregular surface that the normal masks encounter, and it encircles the outside of the face where you would see more regular surfaces. The mask is pretty popular, particularly lately that it has been used very much with pediatric patients in that the mask does not rest upon the cheekbones, which with pressure can be deformed. The hybrid mask originated in the 1990s, and it was an alternate choice to the full face mask for those people who were mouth breathers or were having a lot of difficulty with the full face mask because of leaks. There are two components to the hybrid. There's the nasal pillows that insert into the nostrils and a mouth guard, sort of like an athletic tooth guard, that keeps the mouth closed. Pressures for the hybrid typically range from 4 to 10, although on some occasions they've been up to 15. The leak probability is low to moderate, depending upon the pressure that is used, and the indications are mouth breathers or those people that need a full face mask but are unable to use it. Probably the most popular hybrid is the ResMed Liberty. Next is the PAP hybrid mask, followed next by the Hybrid Pro hybrid mask. In both of these masks, a mouth guard is heated up and fitted to the teeth in order to be secured. The last hybrid is called the F&P Polaro oral mask, which has a nose clip for the nose, and the patient merely breathes through the mouth. After you have selected the type of mask that you want to use with the patient, you're going to use the manufacturer's template or sizing guide to determine the size of the mask that best fits the patient. You're going to place the mask sizing guide on the patient's face, line up the arrows and they're indicated. The sizing guide will indicate the best mask that fits the patient. The mask manufacturers
basically state that if the patient is between sizes, to go with the lower size. Very often, this is not the case. The mask is uncomfortable or painful to the patient. So, what I try to do is just try to find a similar mask by another manufacturer. Many times, not always, but many times, the mask has an in between size and problem is solved. An often overlooked factor in mask fitting is the importance of the headgear. Headgear, everybody thinks of as simply supporting the placement of the mask, but in addition to that, the straps that are tightened to make a better fit also create force upon the cushions, and the cushions are forced to conform to the irregularities of the face surface. What I mean by that is that the cushions will depress into the depressions in the face, and they'll also exert pressures on those high points of the face and try to flatten them. The manufacturers designed the headgear specifically to work with a specific mask. That is, the points of which the head straps attach to the frame of the mask, which again attaches to the cushion, are designed to exert the maximum amount of pressure to spread the cushion over the face so that it can seal all of the irregularities of the face. I'd like to bring up one precautionary note that sometimes in our urgency to try to seal the mask leak, we tighten the headgear straps excessively tight. This pressure can break down the tissue of the skin on the cheekbones, as well as place a lot of pressure on the back and neck, causing much pain. Another step in the mask fit protocol is the placement of the mask on the face. Generally, after we have selected the mask and determined the right fit of the mask, I have the patient open up the package, open up the mask, and then place the mask on their face. I want to give them full control so that they feel that it is theirs and they can take some ownership in this process. Basically, when I have them adjust the straps, sometimes I have to hold the mask in place, but I let them adjust the straps. And in that way, I can see how coordinated they are and how they move their arms in doing so I can evaluate at least their technical abilities to resolve mask problems. Then I start the CPAP or BiPAP off in ramp mode for the lowest pressure and see how the mask fits and if it has any gross leaks or any air leaks directly into the eyes. Following that, I turn the machine on without the ramp and expose the patient to the maximum pressure and again look for any gross leaks. I let it run for 5 minutes or so, just so that if there are problems, they may turn up. But also my other intent is to allow the patient to really feel the mask at that pressure and have the ability to let me know if it's uncomfortable or is it painful. One of the things that I've learned in the last couple of years is the use of the leak rate that is available on the ResMed and the Respironics machines and also on the Trilogy ventilator. When I have the patient adjust the mask, I have them look at the mask leak rate that's being displayed, and I use it as kind of positive reinforcement to allow them to see the effect of their efforts. I think the feedback that they get in watching the leak rate drop as they adjust the mask gives them that positive feedback that they need for better confidence in the mask. The conclusion of our mask fit protocol, which I feel is extremely important, is always to provide the patient and the caregiver a contact number to call if problems arise. I always contact the patient the next day to find out how the mask fit and to allow them to feel that they're being looked after. Finally, be prepared to meet with the patient as soon as possible if a mask leak persists, just to keep up their enthusiasm and belief in the therapy. I'd like to talk about the 7 factors that I believe are critical with regards to mask leaks. They are facial asymmetry, REM sleep, mouth leaks, oily skin, worn old headgear, and wrong mask size. But perhaps the most important factor is the role of high pressure. Generally speaking, as pressure increases, the probability of a mask leak increases proportionately.
But high pressure in the range of 18 to 30 centimeters of water definitely amplifies the effects of all of these factors for mask leaks.
I would like to discuss the differences between a significant and a non-significant mask leak in terms of judging how well the mask behaves. I'm going to define a significant mask leak as one in which the leak rate equals or exceeds 25 liters per minute, and the AHI, apnea-hypopnea index, is greater than 5, as opposed to a non-significant leak in which the leak rate is less than 15 liters per minute and the AHI is less than 5. From this, looking at the graph, a lot of therapists try to make a judgment as to if this is a major leak and the mask needs to be replaced. But I think on the same report, you can get what percentage of the night the mask leak occurred and at what average leak rate there was throughout the night. So I'm thinking that mask replacement due to mask leak is going to be dependent upon the severity of the leak, how much time the leak occurred over, and also whether the patient had a bad night of sleeping or was unaffected. And most importantly, how many days in a row did this mask leak occur? Is it consistent or is it inconsistent? There are certainly many approaches to try to correct a mask leak. For instance, if the patient is calling you on the phone and saying that the mask is leaking and they've tried everything, I would have them put the mask on, turn on the machine, and adjust it so that it feels good and see if it's still leaking during the day as it was during the night. Many times they don't get the leak that they had at night. Quite frequently, a lot of the leaks that occur late at night I call REM leaks. During REM sleep, all of the facial muscles as well as the skeletal muscles of the body are paralyzed to prevent the body from acting out dreams. And so when this happens, the mask that was perfectly tight is suddenly loose and leaks occur. But then when the patient wakes up from his REM sleep or his dream state, his muscles are restored and the mask stops leaking. If we're not able to resolve the mask leak over the phone, certainly invite the patient to come in, and I'll have them demonstrate again how they put on the mask, and we'll try to go through all of the steps and see where the leak is occurring, if it does leak, and go from there. We have many aids that are used for correcting mask leaks. In the first picture in the top is called the gel pad, and we apply this to the patient who are having mask leaks that tend to go into the eye. It's very easy to apply it and put the mask over this gel pad. Another approach might be to use elastic tape and tape that over the bridge of the nose and along the sides of the nose if leaks are occurring in that region. When you have a patient that has a nasal mask or nasal pillows and they're leaking through their mouth, one of the things that you could try is to use a chin strap. Basically, the purpose of the chin strap is to immobilize the jaw to keep it from sagging. In no way does it seal the mouth. The chin strap is a passive restraint. It does not fully seal the mouth. On the bottom row of the first picture is what's called a mask liner. That's called the REMZ. That's a pretty popular device. It's made out of soft white cotton. It fits. It comes in different sizes that fit different sizes and styles of masks. It's been really effective. Unfortunately, the insurance does not pay for it, so the patient has to pay for it out of their own pocket. The mask liner has been effective in sealing a lot of minor leaks, and it gives the patient a lot of comfort. The next aid is in the middle. It's the clear mask liner, and it's made out of gel. It seems to work, but I've not seen it used very often. The third picture on the bottom row is another type of a cushion. It's made out of foam, and sometimes changing the type of the cushion allows more compression and conformity of the cushion to seal leaks. Finally, the last picture on the bottom is the cleaning fluid or cleaning solution, and I always recommend that to make sure that the mask surface is clean. I try to remind my patients that soap and water and cleaning off the oil on the surface of the mask probably has a little bit of a better advantage than using other products. Such products like So Clean and other things use ozone to disinfect all of the different bugs and everything that are in the mask, but I don't think that they clean the oil off as better as soap and water.
And this was a pilot study that I did at the University of Michigan MediQuip home care company in 2017. At that time, we were doing about 300 setups, CPAP and BiPAP, per month, and we had a very generous mask exchange policy based upon the manufacturer's mask promise and also the willingness of the insurer to replace the mask. So we were looking again as to why we had so many patients coming in to get a new mask. So we conducted a study for 21 days or 20 days, and then we decided after that, let's just continue it on. So we continued it to 51 days, which was about 10 weeks. The first category was the number of patients. So we looked at initial mask failure. That was patients that had been set up with a CPAP or a BiPAP, and within 2 or 3 weeks, they came back for a mask. 45% at 20 days, but then that rose to 57% at 51 days. We then looked at patients fitted with a mask for the first time. These were patients that had had a home sleep study, had never been into the sleep lab for titration, so this was their very first experience with seeing a mask. 24% of the patients coming in were at 20 days, and that stayed relatively the same at 25.9 at 51 days. Finally, we looked at masks that were prescribed by the physician. Admittedly, we could have broken this down, but we just did it as very crude, and it was just all prescriptions. So 30% at 21 days, 33% at 51 days. This was as opposed to the therapist choosing the mask based upon all the evidence that he had before him. The next category was reasons for the mask fit or refit. We looked at patient discomfort with the mask, and we found 41% at 20 days and 51% at 51 days. We then looked at patients' complaints or dislike that they presented to their physician who wrote a prescription for the mask refit. 30% at 20 days, but then it decreased to 10% at 51 days. We looked at excessive mask leaks. They were 10% at 20 days and 19% at 51 days. We looked at skin irritation and breakdown, which I thought would be large, but instead it was much smaller. 7% at 20 days, 11% at 51 days. And finally, we looked at claustrophobia. These were patients that came in with no explanation about claustrophobia, but it developed as they started the therapy. 5% at 21 days or 20 days and 6% at 51 days. We then thought maybe our reason for this was patients using a particular type of a mask. And full face masks at 20 days were 41%, 64% at 51 days. That kind of confirmed our suspicions about the type of mask. Nasal mask, 43%, which I was really surprised at 20 days, but then that dropped to 5%, which was more like my experience. And finally, nasal pillows, which was a big shock, 15.2% at 20 days, and that rose to 31%. I believe this may reflect the non-invasive nasal pillows coming in, which just fitted lightly on the bottom of the nose, but really didn't insert into the nostrils. Finally, we looked at prescribed pressure. We were convinced, at least in our head, that a lot of this was due to excessively high pressures. So we looked at all pressures, and basically there was hardly any difference between 20 days and 51 days. Average pressures, 12 centimeters of water, 12.6 at 51. Pressures that were in the range of 4 to 17 centimeters of water, 10.2 versus 10.3. And finally, all pressures ranging between 18 to 30, 21 and 21.2. So that was really a surprise to us. Overall, again, this was a pilot study. We're just kind of peeking at what was out there. We had plans to redo this study and make it really more specific into the details. Unfortunately, we never had a chance to go back and to review the data and conduct another study, so this is where it came. But probably what I think is more value to you would be the surprising thing with mask discomfort, 51%. I thought other factors would be much larger, but this turned out to be the biggest factor for patients wanting to come in for a mask refit. So please note that for your future mask fits.
We're going to try a little change of pace here. We're going to take an actual patient of mine, and we're going to do a facial assessment, and we're going to see the effects of the facial assessment and their bearings upon what happens when the actual mask is applied to his face. So I'm going to have you look at the face and see if there's anything that stands out. Look at the bridge of the nose, look at the sides of the face, the frown lines, look at the lips, look at the corners of the mouth, look at the skin, look at the cheekbone, look for asymmetry. Just scan this just as you would one of your own patients. And also think about what kind of a mask would you fit on this individual. We'll just say that his pressure is 30. As we take a close-up look at the face, we can see that there's a pressure sore right on the bridge of the nose. If we look further, right on opposite sides of that pressure sore, it looks like the surface of the nose curls in, which are opportunistic locations for the air to flow into the eyes. Looking a little bit farther down the nose, we see where the frown lines are. They're actually curled around to become folds. Again, another source of air leaks for the mask. Then finally, looking below the lips, you see that it is raised and swollen, and this is above the gun line, so it's like the mask is pushing on the lower part of below the lip against the actual teeth. Looking at facial asymmetry, it's not really apparent, but when you look from side to side, you can see that the cheekbones on either side are on equal heights. It appears that his right side cheekbone is a little bit higher than his left-sided cheekbone. When the patient puts on his mask and turns on the machine, which is set for pressure of 30, it is evident that the facial irregularities that we're noting are coming into play. The first thing that you see is that the mask is definitely shifted. It is not dead center, but it's shifted more over to the right side because of the high cheekbone. Notice again that the upper part of the frame of the mask is cutting deeply into the cheeks. Notice that the lower straps also cut deeper into the lower part of the cheek, and the straps are causing a lot of pain and discomfort in the back of his neck because it was adjusted so tight. So you've seen all of the facts of this case, but what would you, in your mind, think of doing that could remedy the situation or make the situation better? Of course, everyone's saying, well, let's try some different masks, but this patient has tried already 15 different masks and all came out with the same problem, that it was still leaking very badly and causing him a lot of pain. So what we tried to do over many weeks was to try to step-by-step use some different types of aids to try to relieve the pressure. So we were able to put foam on the back of his neck to relieve the pressure from that, and that really helped. We also used some of the gel pads underneath his cheekbones to try to even out the frame so that it fit a little bit more properly. And doing these small adjustments over a period of time, we were able to correct the mask leaks and allow him to continue using the machine. We're going to change the focus now a little bit to where we are now with mask fitting and what lies in the future for us. The facial scanning technology that we have today evolved from facial recognition technology that the military and the governments were using in the early 2000s and before that. Basically, there are 4 methods that are used to assess facial irregularities for mask fitting. We have explored the traditional assessment. Another method is the 2D picture or single selfie picture taken with the iPhone or iPad or any other type of a camera. The picture is submitted to the home care company or the manufacturer, where the picture is assessed by a computer. using a specialized algorithm that makes a recommendation for the type of mask and size. The third method is photogrammetry, which uses a single camera to take a series of pictures to construct a 3D facial model. The algorithm then goes through a list of masks and selects the right fitting mask and size based upon this 3D model. Finally, the last method for scanning the face is a 3D scan by multiple cameras of high resolution to construct a 3D facial model and for the eventual printing of the 3D mask. Currently, mask manufacturers received kind of a setback with the pandemic and all the restrictions about that. Philips Respironics released its new process for companies to follow, in which the patient takes a selfie picture of their face and submits it to the company, which then forwards it to Philips Respironics for analysis, and they make a recommendation about the mask and the size without having to go and personally contact the patient and do a physical assessment. The quality of the image is going to vary with the megapixels of the actual camera, but they haven't made any restrictions upon that. On the picture on the right is a scan that I did of the patient, and I used an iPad to do the scan, which was low resolution. And as you can see, there aren't a lot of details that come through, but there is enough information coming through the photo in order for the computer to make a good analysis of the face and make a good recommendation for the mask and size. Earlier this year, ResMed launched its remote mask selector process by which a patient could work with the home care company, answering a few questions, providing contact information, and then measuring the size, the length, and the width of their nose. That information would be relayed back to ResMed. With their computers, they would make a recommendation on the types of masks and the sizes that would be appropriate for their fit. The generated mask recommendations would be covered in an interview with the patient by the respiratory therapist. Then the mask would be delivered to the patient. Then the respiratory therapist would call the patient and go through all of the procedures with regards to mask fitting and teaching them how to put it on, how to adjust it, and how to look for a leak. However, the respiratory therapist is not going to be entering into the patient's home. Philips Respironics also had plans to launch this year a new type of mask fitting program using a high resolution facial scanner to create a three-dimensional view of the patient's face, then using a sophisticated computer algorithm to evaluate the face and make a good recommendation for the type of mask and the size. According to Philips Respironics literature, the camera would take 150 frames or 15 million points of facial geography data. Then the algorithm would identify 46,200 data points in recommending a mask. If you read the fine print in the upper right-hand corner, Philips Respironics states that they did a study of 380 patients, and 9 out of the 10 patients only had to be fitted with one mask. Then below that, it shows that they reported that 48% of those patients were able to complete the 90-day compliance trial with that mask. The last method for facial scanning involves the company called MetaMason. They do, as I call it, an extreme 3D digital facial scan involving 3 cameras. They are easily able to construct a extremely detailed and high-resolution 3D model of the patient's head, and they use this model to construct the 3D mask that fits extremely well to the patient. Every contour is met. Because of the degree of resolution in their scan, they can easily construct a mask that is very custom fit to the patient's liking, or construct a very specialized mask that the patient might even enjoy, as shown in the picture above. Further, they can construct a cushion to fit an existing proprietary mask that is exactly molded to their face. I'd like to take this time to talk about predicting the future of mask fitting. I really believe that the human element involved in the mask fit protocol is going to be taken over by computer algorithm. Don't get me wrong, respiratory therapists will still play an important role in the mask fit process, but they'll be using the computer and facial scanning to achieve much, much better accuracy. High resolution scanning equipment will be available in sleep labs, hospitals, and DME locations. Despite the claims of high accuracy of technology in mask fitting, respiratory therapists will still be needed to correct the problems involving mask leaks. Respiratory therapy will still do troubleshooting of mask fit problems with the patients over the phone remotely. I really think that the market for customized 3D printed masks will continue to grow, but I think ultimately the 3D printing is going to be replaced by holographic technology, which will advance the precision of imaging of mask construction and fitting. With a 3D view of the patient's head and mask, it'll be easy for the patient to select a custom mask type that they like, and the computer will do all of the rest of the work of creating it and printing it, and they'll have their mask within an hour or two. I'd like to wrap up this lecture by reviewing all of the things that we've talked about today. So we've discussed the factors of the successful mask fit. We've described the traditional mask fit protocol. We've described the purpose of facial assessment. We've gone over the indications for the various mask interface categories. We've described the factors for selecting a proper nasal mask. We explained the difference between significant and insignificant mask leaks. We described factors that contribute to nasal mask leaks and how to fix them. We've described the current conditions with the pandemic of how mask fitting is being accomplished. We've described the differences between 2D and 3D facial scanning. And finally, we've talked a little bit about what I believe is going to happen to the future.
I'd like to conclude this lecture with my last thoughts. CPAP and BiPAP masks have been with us for 40 years. Mask leaks have been persisted the entire time despite the advancement of technology. CPAP, BiPAP, and non-invasive ventilation have greatly expanded in use but are still dependent upon masks for success. Why do we have so many types and styles of mask if we are advancing so much in technology? Where are the studies and the data regarding the successful and/or unsuccessful application of masks in resolving leaks? The overall national CPAP BiPAP compliance adherence rate is still around 50%, kind of similar to our finding of patients newly set up who wanted to get a new mask. Could much of the CPAP and BiPAP noncompliance be related to uncomfortable masks? The thing is that we have technology, we now have a little bit more knowledge, but it still is a human factor in terms of how we treat the patient, how well we do the mask assessment, how well we do the mask fitting, how well we follow up with the patients, but mostly how can we coach the patient to get over a lot of these inconveniences.
I hope you've enjoyed the presentation. I wish I could have delivered this presentation to you in person, but unfortunately things are what things are. But if you do have any questions or comments, please contact me at